Welcome to the Advanced Cardiac Life Support Training video. This video was produced at Colonial War Memorial Hospital in Suva, Fiji. This presentation will focus on two important aspects of advanced cardiac life support. Firstly, the management of shockable rhythms, especially emphasizing the importance of early defibrillation and good quality CPR. And secondly, the importance of good teamwork, including clear communication and skill development for all members of the cardiac arrest team. Electrical defibrillation provides the single most important therapy for the treatment of patients in cardiac arrest secondary to a shockable rhythm. For this reason, great emphasis is placed on early defibrillation. The greatest chances of survival result when the interval between the onset of arrest and the delivery of defibrillation is as brief as possible. High-quality chest compressions are also important, as they maximize blood flow to the brain during the time of cardiac arrest. This can be an important determinant of patient outcome. As soon as a patient is found to be unresponsive and not breathing normally, CPR should be commenced at a ratio of 30 compressions to every 2 breaths. The rate of compressions are to be delivered at 100 to 120 per minute, which is nearly 2 compressions every second. The depth of compression is to be 5 centimeters or 1/3 the anterior-posterior width of the chest. As soon as the defibrillator is available, the paddle should be used to assess for the cardiac rhythm. If a shockable rhythm of ventricular fibrillation or ventricular tachycardia is identified, then a shock of 200 joules should be delivered immediately. Due care should be taken to ensure that all members of the team are standing clear of the patient when the shock is delivered. CPR is then recommenced immediately. This flow diagram further illustrates that CPR is commenced as soon as possible after post-cardiac arrest, and it highlights the importance of early defibrillation. After the second to 100 joules defibrillation is performed, adrenaline 1 mg is given intravenously. It is then administered during every second cycle of CPR. After the third episode of defibrillation, amiodarone 300 mg is given intravenously to the patient. In between defibrillation, good quality CPR at a rate of 30 compression to 2 breaths is continued. Whilst performing resuscitation, the underlying cause of cardiac arrest needs to be considered. Going through the 4 H's and 4 T's as a team can ensure that no potential cause is missed and not treated. During resuscitation, hypoxia can be addressed by good bag valve mask ventilation with oxygen. Hypovolemia can be treated with a fluid bolus. Hypokalemia should be considered in renal patients. Tension pneumothorax needs exclusion in trauma patients or if one side of the chest is not moving properly. Thrombosis, especially cardiac, is a common cause of cardiac arrest in Fiji. However, none of the above is possible without effective teamwork and communication. The better you work together as a team, the better the potential outcome for your patient. That is why it is so important that you don't just understand what to do during a resuscitation, but how to communicate and perform as a team, regardless of whether you are the team leader or a team member. Clear team leader is important during a resuscitation attempt. They should be doing most of the talking and overall directing. This allows those who have been allocated specific roles to concentrate on their tasks, for example, drawing up drugs. However, all team members are important and they must speak up when something is not going well during the resuscitation or if you notice that something has been missed. Role allocation needs to be specific. This ensures that all important jobs that need to be performed during resuscitation are done. It also avoids multiple people or nobody attempting a task. Using people's names when allocating roles make it clear who is performing each specific task. By repeating back verbal orders during a cardiac arrest, we are using closed-loop communication. For example, Mary, can you please give 1 mg IV adrenaline now?
1 mg IV adrenaline being given.
Said Mary, 1 mg of IV adrenaline has been given. This is critical because in times of stress, we may not say exactly what we are thinking. By repeating the order back verbally, any errors made by the person requesting or receiving the message has an increased likelihood of being corrected before it is too late. It also ensures that all members of the team know what has been done.
Hello Raymond, I'd like you to assess John A. John A's come to the triage desk with chest pain. He looked pale and sweaty and then he collapsed.
Johnny.
There's no response.
Thank you. Team, I need help here. And then Noah, can you start doing chest compression? Alessi, to look after the airway. Salati, could you be a scribe for this? Elisabeth, get ready with our monitor, and could you attach the monitor and let's see what's happening with our patient. Okay, stop the chest compression, let's see. Okay, we have continued chest compression. Elisabeth, get ready with our shock.
Charging at 200. Stay clear. Shock delivered.
Thank you. Continue chest compression. Thank you. Rhythm check. Phase change. Still we have continue chest compression, and Elisabeth, get ready with the second shock.
Charging at 200. Stay clear. Shock delivered.
Thank you. Continue CPR. Elisabeth, could you give adrenaline?
Adrenaline 1 milligram.
Adrenaline 1 milligram given. Thank you. Thank you. Rhythm check. Still we have continued chest compression. Elisabeth, get ready with a flat shock.
Charging at 200. Stay clear. Shock delivered.
Thank you. Elisabeth, get ready with our epidural.
Should we give up Neodrone? 300? 300.
Okay, we've given our third shot. Can we consider our 5 H's and 5 T? Have we ruled out all our 5 H's and 5 T's? Okay, thank you. We've ruled out. Rhythm check. Okay, still BT. Still VF, sorry. Continue CPR, and Elisabeth, get ready with our fourth shot.
Charging at 200. Stay clear. Shock delivered.
Thank you. Continue compression. I think we have a rhythm there. Could you stop Eleanor? Let's check. Yes, we have a rhythm. Could you just check for the pulse?
There's a strong pulse.
There's pulse there. Thank you. What's the saturation like?
Saturation's 94%.
94%. Okay, you can just elevate the head of the patient, Leslie, and make sure that's good airway. And Elisabeth, could you just take the blood pressure for us? And Eleanor, 1 ECG for the patient.
Respiratory rate is 12.
Thank you. Respiratory rate is 12.
Blood pressure is 90 on 60.
90 over 60. Faith, could you hook up one normal cell line?
ECG shows anterior STEMI.
Line put up.
Okay, the ECG shows anterior STEMI. Let's get ready with the streptokinase treatment and shall call the medical registrar, the cardiologist, to come and verify for us.
In summary, this presentation has focused on two important aspects of advanced cardiac life support. Firstly, the management of shockable rhythms, especially emphasizing the importance of early defibrillation and good quality CPR. And secondly, the importance of good teamwork, including clear communication and skill development for all members of the cardiac arrest team. Vinaka.